Okay, hello everyone. Thank you for joining me for our last leg of this marathon of pediatric ultrasound information. We're going to get started with renals today. So the renals, as we know, are a very important part of the retroperitoneum. It's one of the most commonly completed ultrasound done for our pediatric patients because of obviously the lack of radiation that we expose them to and the fact that their kidneys are actually pretty easy to scan based off of their body habitus and lack of the bowel gas that we're usually fighting with our adult population. So usually if a patient is suspected, a pediatric patient is suspected of having a renal abnormality, the first thing they're going to come to is ultrasound. Um, Oftentimes we're following up with our newborn patients when they found prenatal sonography abnormality or suspicion. And so we are looking at these newborns to see if the findings are continuous or if it's something that has resolved. For our older infants and younger children population, the most common reason that we're going to be scanning these patients is really usually due to recurrent urinary tract infections, painful urination or enuresis, or excuse me, dysuria, frequency of urination, urgency of urination, and the suspicion of any urinary reflux, which we know puts these children at risk for kidney infections. Less common clinical indications for our pediatric population are going to include suspected mass palpations, unexplained hypertensions, because we understand how closely related that our hypertension and our renal artery system are associated with that renin-angiotensin feedback system. Also, tuberous sclerosis, which remember is an abnormality that affects the person throughout their body system, resulting in mental retardation, kind of around tuberous chest. It's associated with angiomyolipomas in the kidney. These are patients that they're going to start watching very closely from a young age. Hemihyperplasia, where you actually have one side of the body growing faster than the other side of the body or growing more continually, that can also be associated with multiple renal abnormalities. Pre-renal, post-renal transplant, obviously we're going to be looking at what they have and what they're going to get, looking for vascularity in those new transplant patients, things like that. Patients with suspected or known multicystic kidneys, we can monitor those to see how they are changing over time, as well as with our polycystic kidney patients. Prune belly syndrome, this is another one that really affects the urinary tract as well as the abdominal wall. So we're going to be watching for that. It's associated with the posterior urethral valves as well, which can have a major impact on a patient. And ultimately, we're always there to assist in the need of renal biopsy guidance. So sonographic technique for the kidneys, obviously we know no prep is required. Adequate hydration is preferred because that's going to make the kidneys usually stand out a little bit better and be a little bit easier to image. Now, if ideally, because the reduction in bowel gas, fasting is always preferred, but for our pediatric population, much of the time that's going to be difficult or out of the question. Kidneys can be imaged like with adults, usually from the patient side or the coronal planes or the anterior planes, but they can also, in the pediatric population, be evaluated from the posterior surface. So placing your patient in prone and evaluating posteriorly can give you really nice access to those kidneys. Now, if you're having to work around the rib surfaces, those usually aren't as calcified as they are in our adult population, so you can get through those a little bit easier. If you want to go intercostally between the ribs, then you're going to have to utilize one of those smaller transducers, something like a sectors or something like that, to be able to get into those spaces. The challenge with kids with everything is that they can be unwilling or unable to hold their breath and obey instructions or hold still or do all of the things that would make our jobs much easier. And so really being able to communicate with the child and the patient's parents is going to be integral in trying to make the best study you can. That being said, sometimes it works, sometimes it doesn't, so you have to be ready to work on the fly when it doesn't. For neonatal examinations, the higher frequency transducer that you can use, the better. That's going to, these neonates are not going to require a lot of penetration, so usually you can get away with a high frequency transducer from 10 megahertz to even higher, oftentimes meaning that you're actually going to be going with a linear versus a curvilinear, which we really aren't used to for our abdominal studies. In young and premature infants, like I said, you can even go up to a 15. The higher frequency, obviously, the better your spatial resolution is going to be. And so you got to balance that, getting the penetration you need with the spatial resolution, and then finding a footprint that is not too big to get into the small spaces that you're looking at on these children. So if we do a quick review of the normal appearance of the kidney, we're going to look first at a basic diagram here where you see the outer portion of the kidney. That's going to be our cortex. Remember, that's where our nephrons begin, and that's where our glomerulus is going to be contained. Remember, then the glomerulus is going to have that descending and ascending nephron tube that's going to go into our pyramids here. So the pyramids are considered part of the medulla. So here we have the cortex. Here where we have the pyramids, we're going to have the medulla. We can have columns of Bertin that separate these medulla, or excuse me, these pyramids, and those are basically going to be the cortical tissue that is kind of falling in between, separating those pyramids. At the distal end of the pyramids, we have the papilla. Those are going to drain the urine from the pyramids into the minor calyces. Multiple minor calyces come together and they will make a major calyce. The major calyces are going to come together and they are going to form the renal pelvis. That renal pelvis is then going to communicate with the ureter here at the urethral pelvic junction, or the UPJ. Now, when we're looking at our kidneys on ultrasound, we're going to be seeing, especially in our pediatric patient, you might really note, first thing is how prominent the pyramids can appear and how much better you actually see the kidney. So it can be kind of overwhelming where you might think something's abnormal, and it's really just because you're seeing that kidney so much better. The renal pyramids should look a little bit triangular. We should be able to measure that cortex. You're definitely going to see a different transition of texture between the cortex and the renal pyramids. Remember, the pyramids are going to be separated with that cortical type tissue called the columns of Bertin. In 70% of kidneys, a compound renal pyramid or a normal hypocoque medulla region can occur. So a compound renal pyramid would basically say that we don't have that column of Bertin separating the two pyramids, so you might see them kind of communicating together, and that would be relatively normal to see. If we see these, usually they're going to be in the upper pole, but of course they can occur anywhere. So with the kidneys, as I mentioned, that we can have the compound calyces. That's a group of calyces that come together in one infundibulum. So where we go from the minor calyces to the major calyces, it would be a bunch of minor calyces draining into one particular area before it gets to the major calyces. These are also associated with compound pyramids, where we have multiple pyramids joined in one group. They're all draining into basically a group of calyces that are communicating with one another before they're really supposed to. Fused pyramids can appear as irregular hypocoque areas. There's not associated evidence of renal, pelvic, infundibular, or calyceal dilatation with fused pyramids, as there is with the compound pyramids. If obstruction does exist or other renal abnormalities are present, renal pyramids can come compressed and poorly visualized. So when we see things like severe hydronephrosis, that's when you can see, almost that cartoon glove sign where all of the renal pelvises kind of are compressed and lobulated rather than looking like your typical renal pelvis. So here's a couple examples of a pretty normal fetal kidney. As you see, this one appears more echogenic than we might expect in an adult, and that is actually very normal in your newborn kidney. You can even appreciate in this particular image, we see the liver here, we see the kidney here, and you can even see the right adrenal there, which is also much more prominent in our pediatric population. Here on our second image, we see, again, a very normal neonatal kidney. We do see that there is a little bit of normal fetal lobulation And so with this, this is something that is going to be pretty common in your younger population to see that lumpiness. So don't get alarmed that there's a mass or something there. You have to consider that. You have to look for it, but most likely it's just normal fetal ovulation. Here's another example here in this image where you can have a normal junctional defect. So here is a normal junctional defect where basically the kidney kind of came together at this particular area and it left this little fibrotic area. It will look like basically a arrow of echogenic material pointing into the kidney. And that can persist through life. I know in our lab, I've showed our students in Elko that I actually have one of these. It's pretty common. You guys have probably seen them on each other in your other labs as well. Okay, so as I mentioned, the columns of Bertin, they're actually those foldings of cortex that come down in between the renal pyramids. They are not separated by papilla because they stop before the bottom of the renal pyramids. The cortex, as you know, it's thin compared to the medulla. In adults, it's about 1 centimeter, but we can't predict exactly the thickness it's going to be because that's in pediatrics, because it's going to be based on their age and their size. The renal sinus is less fat-filled in infants and young children because they haven't had the time to build up that fat there yet. And so we might see a more prominent renal pelvis during infancy than we would see in our adult. Now, in childhood, usually about half of that renal pelvis is located outside the renal sinus. So as we may refer to that in an adult population as an extrarenal pelvis, in the pediatric population, that would be expected. The renal pelvis should measure less than 10 millimeters, which would be 1 centimeter in AP dimension. So if you have your transverse and you're measuring it across the renal pelvis, it should be about 1 centimeter. More than that would be indicative of a little bit of hydronephrosis. The renal pelvic wall also should not be visible. If we start getting visibility of that pelvic wall, it probably means that there's some sort of infection or some long-term damage to that pelvic wall, causing it to become fibrosed. So what we should see is just a transition or a very, very thin pelvic wall in these pediatric patients. Here's an example of a patient that has probably had some longer-term kidney disease. Maybe they've had some infection over time, and you see that you note this probably larger. If we were in AP dimension, we could measure it for sure, but here it's greater than 1 centimeter in our renal pelvis. It also shows a thick echogenic walls here in the renal pyramids. And because of that echogenic wall with the shadowing would be very abnormal, and it is indicative that there's been some damage done, probably some fibrotic, even calcified changes in the pyramids, and so that is giving it that appearance. This particular infant had a history of posterior urethral valves and urinary tract infections, and we know with posterior urethral valves, typically that's in our male patients, they're unable to void their bladder. That's going to cause the urine to back up into their whole urinary system. It backs up retrograde, so the bladder will fill first, and then since the bladder can't empty, that dilatation goes into the ureters, and then that dilatation will go into the kidneys, and all of that urine sits in there static. And we know with static urine over time, that's going to cause infection and can cause some damage to the kidneys here. Okay, cortical echogenicity is going to change over time. So if we look at the cortex in our newborn, usually that's going to be a little bit more echogenic than the liver and the spleen. By the time they get to about 6 or 8 weeks, then we see it become more isoechoic to the liver and the spleen. By the time they're 2 to 6 months, then it becomes a little bit hypoechoic to the liver and the spleen. Now we know in our adult population, we expect it to be pretty isoechoic to the kidney and the spleen. And so it's during that late infantile and pediatric period that it makes that transition. Now, neonates with cortical echogenicity that persists and they stay very hyperechoic, that would be indicative of parenchymal disease or something like we talked about with that previous image of the posterior urethral valves. It's causing something in that cortex to become echogenic. Some specific pediatric conditions that will result in that prolonged cortical echogenicity would be things like leukemia, which, remember, that's the white blood cancer, so don't get that white blood cell cancer, don't get that confused with our lymphoma. Lymphoma would most likely cause it to be hypoechoic. So with our leukemia, we're going to see it stay hyperechoic. Glomerulonephritis, remember that is inflammation of the glomerulus. So if there's damage to the glomerulus and the glomerulus is in the cortex, it would make sense that over time that damage would cause echogenicity, fibrosis, and calcifications. Nephrotic syndrome can also lead to this, as well as renal artery stenosis, where that tissue is not getting adequate blood supply, and therefore it is going to oftentimes fibrose because it can't function without its blood supply. Chronic infection, it will also cause that increased echogenicity just by doing that long-term damage over time, leading to fibrosis and echogenicity. So the normal sonographic appearance, we know that on our kidneys, in our adults, we measure the kidneys, especially in their length, is going to be very indicative of whether the kidney is probably adequate size and adequate function. In children, of course, this is going to be harder because we have children of all different sizes. So the measurement or the length measurement of our kidneys in our pediatric patients are going to be related to their age, weight, and body surface. This is going to be important that you actually find or know where to find charts that you can refer to assess whether the kidney is falling within the reasonable size or not. If you have a mass, you know you have a mass, you might just be able to say, yeah, that kidney's big, whether you have that length chart or not. But on patients that have a diffuse process, such as infection or leukemia or lymphoma, it's going to be harder to know if it's large or small without those charts. So make sure that you have something available to refer to when needed. In children, the renal vein may appear prominent, so you don't have to assume that there is maybe a thrombus upstream or something like that. It may be just normal for that renal vein to appear a little bit more prominent than in our adult patients. And part of that is because we see it a little bit better, probably, and part of it is because it's just a little bit larger in the context of the overall patient. Fetal lobulations, like I mentioned, this is pretty common, especially in our newborn infants. It's especially present in most premature infants. By 1 year of age, usually there's more smoothing of that kidney, and we don't see the lobulation as much as before. Now, that lobulation can be confused with scarring, like a pyelonephrotic scar. It could be confused with a junctional defect. So make sure you're really assessing that, looking for that echogenic wedge of a junctional defect and determining, is there really a wedge there or is it just lumpy and bumpy? Okay, now if we look more at the size, a large kidney is 2 standard deviations larger than the mean. Small kidneys are 2 standard deviations smaller than the mean. So if we go to our chart and we take our measurement with us, we're looking at the chart, usually there's going to be a wide range of what's considered normal. You have to be all the way 2 standard deviations outside of that range for it to be considered either hypoplastic or hyperplastic. Abnormalities of the kidneys, especially as it comes to size, can be bilateral or unilateral, symmetric or asymmetric. So if there is maybe hypertrophic kidneys, perhaps there's something systemic that's making both kidneys hypertrophic. So could they have lymphoma in both kidneys? Could it be something like that? If it's one side, maybe one side's much larger than the other, then maybe there could be a mass in that affected side. If you have one side that is very large and the other side that is very small, that could be that one side isn't functioning, so the other side is compensating, and that's when you're going to get compensatory enlargement. This usually occurs, that compensatory enlargement, if you have only one functioning kidney, will usually occur within 6 to 12 months following either the death or atrophy of one of the bad kidney or the surgical removal of that kidney. So it takes a little bit of the time for the good kidney to become enlarged. Now, just like we do on our adult population, we can use a duplex Doppler to assess our renal arteries. So that's going to be utilizing our color and Doppler flow. As we expect with our renal arteries in our adult population, we're also going to have a very low resistance arterial waveform in our pediatric population. So remember, with those low resistance waveforms, we're going to have brisk systolic upstroke. We're going to have a quick fall during early diastole, and then we're going to have continuous flow through late diastole. So, so these are going to be our biphasic waveforms demonstrating very low resistance, and that's because our kidneys need so much blood flow to function. The resistive indexes can be determined if a system is dilated or obstructed. You may want to, when you're completing your measurements here of your peak systole and diastole, you can put that into the calculation package where it will come up with your resistive index, which might be helpful in diagnosing things like tubular interstitial disease and other vascular diseases. So here is just kind of a little breakdown of some of the things that can cause bilateral versus unilateral enlarged kidneys. And then when we see small kidneys, these are some of the things that could cause bilateral versus unilateral. So I'll let you go through that chart. As you work through the chart, I want you trying to think about why each one falls to where it does. So, so try and make a case and walk yourself through why, say, a bilateral small kidney could be because of aplasia, or why it could be because of renal vein thrombosis. So here you see some examples where this is actually a renal artery, and if we look here, we have very much of a triphasic flow. So this would indicate a very high resistance pattern that would be absolutely abnormal for a kidney. Here we see something that's more of our typical normal renal artery, where we see that good systolic upstroke, and then we see good flow through diastole all the way through that Windkessel effect, all the way till our next systolic contraction. Okay, we're going to get into some of the abnormalities now. So agenesis, just as the word tells us, it's a failure to form. So agenesis, especially now, if this could be unilateral or bilateral. If this is bilateral, it is going to be associated with oligohydramnios. Oligohydramnios will prevent the fetus from urinating, obviously, or is caused by the fetus's failure to urinate. Because of that, they can't breathe in that amniotic fluid, and therefore they will not have their normal lung development. So most likely this will result in death immediately after birth, if not before, because of pulmonary hypoplasia. It's also associated with Potter syndrome and as I mentioned before, pulmonary hypoplasia. Adrenal glands in this case are well developed. If this is unilateral rather than bilateral, you may not realize that anything is wrong with the child because they would have that good kidney to produce fluid. And if this was missed in utero, then you may not realize that anything is wrong. What you will find is on the side where there is no kidney, the adrenal glands become a little bit, as they become well developed, they're going to measure somewhat larger, and they can actually take up that space that kidney should be in. So you want to make sure that you're not mistaking a hypertrophic adrenal gland for an actual kidney in this particular case. You can always utilize your blood flow, watching it from the aorta, to determine whether it's kidney versus adrenal. Bladder is absent with bilateral renal agenesis. That would be in utero. That would be if they're lucky enough to be, still alive after birth. We wouldn't see a bladder because no urine is being produced. Unilateral renal agenesis is more common, and as I mentioned before, it can be asymptomatic for some time, and it could even be found as an incidental finding later in life. That should be less common these days, as most fetuses are hopefully getting a good obstetric exam during pregnancy. Now, hypoplasia, this is just less than expected development. This can be due to renal infarction, so perhaps there was an issue with the blood supply to one kidney or the other, that would cause it to be stunt its growth, become hypoplastic. Ultimately, if that's blood flow is not retained, eventually it will become basically atrophic and non-functioning. It could also be related to chronic disease, so chronic inflammation like pyelonephritis or reflux nephritis. Keeping it infected all of the time will cause it ultimately, like all of our other organs, to fibrose, give up, shrink, calcify. It can also be due to a hypoxic event where there's not enough oxygen. So even though they may have blood supply, they don't have enough oxygen in that blood supply in order to feed the cells and keep them working. So again, that would cause a fibrotic change and atrophy. Okay, so now, as you guys probably remember from OB class, you've learned about Vater and Vactrol and how you hear an R in both of those acronyms. So with Vater and Vactrol, that R stands for renal abnormalities. And so it with Vater, it's vertebral. I haven't looked this up for a while, so bear with me. Vertebral, anal, renal, vertebral, anal, I can't remember the T, esophageal, and renal. So when we look at this list, we can pretty much pull all these back to having associations with those Vater, Vactrol, or other abnormalities in the genitourinary system, which we know develops with the genitals develop with the urinary system, and so if one has some abnormalities, the other often will too. So when we get that duplicated uterus, vagina, hypospadias, undescended testes, seminal vesicle cysts, vas deferens, all of that is because those things are basically developing in parallel with our kidneys. And so an abnormality in one often means an abnormality in the other. These other GI skeletal systems, those are going to be more often related to those Vactrol and Vater syndromes. Okay, other congenital abnormalities or anomalies would be hydronephrosis. This is probably the most common anomaly in infants and children, and this would be classified as dilatation of the collecting system of the kidneys. It can be very mildly extensive, or it can be very aggressive. So it would be dilation of the renal calyces. That would be the most insignificant form. As that dilatation backs up even farther, then we're going to see the pelvis become dilated, the ureters may become dilated, and this can all be caused by a multitude of issues. So lots of times this is caused by some functional causes. So maybe there is no peristalsis in the ureters, or maybe there is reflux from the bladder. So a lot of that can be some mechanical or function causes. Other cases could be obstructive, where there is a large stone or a urethral or something like that that would be having mass effect and causing it to not be able to drain. Now, a VCUG stands for voiding cystourethrogram. This is something that we can do in radiology, where they use fluoroscopy or live X-ray, and they basically start a catheter in the patient's bladder, and they put radio opaque, or it'd be white contrast, a white appearing contrast, into that bladder, and then they watch for reflux to go from the bladder into the ureters. Then they'll have the little one urinate, and they'll see upon that act of urination, or also known as micturition, if there's any reflux into the ureters. And that will help them determine if that reflux is the cause of hydronephrosis, and if that reflux is probably going to impact that patient as far as having recurrent urinary tract infections and things like that. So reflux at the vesico-urethral junction accounts for about 14% of cases of hydronephrosis, and can occur with obstructive bladder lesions. It can also occur with duplicated collecting systems. neurogenic bladder, an abnormal insertion of the urethral angle into the bladder. So a lot of different things can cause that reflux. The reflux can then go on to cause hydronephrosis, and then the hydronephrosis can go on to cause infection, inflammation, and other issues. So most of our young patients that have recurrent urinary tract infections, they're either going to come in, they're going to get a VCUG, or they can come in and they can get a sonography exam of their kidneys, bladder, really, and we're always going to be wanting to pay attention, looking for any sort of that reflux or any cause that might cause reflux. Another cause of hydronephrosis could be uretropelvic junction obstruction. So this would be some sort of obstruction, usually congenital in our infant population. That would mean that the kidneys are functioning, they're producing urine, and yet there's some sort of obstruction from where that urine is supposed to enter the ureter, causing hydronephrosis to back up into the kidney. So that can do long-term damage to the kidney, so these things need to be addressed quickly. So here's a couple examples where we see in this particular case, we don't see any of the ureter in this case, unless this happens to be the ureter, I can't tell for sure. But what we do know is that this is definitely greater than 1 centimeter across our renal pelvis. This is where we're already getting compression into the minor calyces, and really compressing all the way into the pelvises here, and here. It's going to go so extensively if this is not addressed that it's going to compress that cortical tissue, causing a reduced blood supply in that area, and that will ultimately result in atrophy and fibrosis of the cortex if it's not already affected by inflammation and infection. Here you see that we see a ureter that kind of has that sausage look, and this would be indicative of something distal to the ureter, so maybe a vesicoureteral obstruction, a posterior urethral valve, something like that would cause this back up into the ureter. Ultimately, after this ureter gets to its maximum size, then we're going to see that collection of fluid within the kidney. So here in this image, we see a severe case of hydronephrosis, to the point where really the renal parenchyma is being so compressed that ultimately it's probably going to start functioning. It's going to start thinning, as you can see, especially in this right example, very thin cortex, and we know that's where all of the action takes place in that urine production. This pressure of that fluid is also going to compress on the vascularity of that area, and ultimately function is going to be decreased because it's not getting good oxygen nutrient supply with vascularity. Those cells are going to start dying, and it can ultimately lead to complete renal failure on this side, and atrophy and non-functioning of that kidney. Okay, now we talked about some of those more proximal urethral obstructions, like the uretropelvic obstruction that's going to back up just into the kidney. But those distal urethral obstructions, they're actually going to be the most prevalent cause of our pediatric hydronephrosis. So that's usually going to be more towards the bladder area. We can have megaureter, which tells us from the term that we're going to have a dilated ureter. This can be caused by multiple different causes. It could be something that's idiopathic. We don't understand why it occurs. There's no reflux and it's not obstructed. For some reason, they just have a ureter that is not draining urine. It could also be caused by a distal stenosis or stricture, so narrowing of that distal ureter, or a stricture of that distal ureter could be impacting flow, causing the urine to back up in the ureter, resulting in a megaureter. Most distal ureter is most common, there can also be a factor where the most distal end of the ureter is just unable to conduct a peristaltic wave, which would push that urine through down into the bladder, and therefore, because of that lack of motion in that area, it's going to cause a backup in the production of a megaureter. Now, most of the time, these distal urethral obstructions, if they're bilateral, they're going to cause bilateral hydronephrosis. It could take some time for that to occur, as it's going to be a retrograde process. So bilateral hydronephrosis is usually caused by some sort of obstruction at the urethra, that exit to the bladder, which is going to back up the bladder, back up both ureters, and then back up both kidneys. It could be something in the bladder, like a bladder mass or something like that, that is affecting the bladder's ability to drain as well. So anytime we see bilateral hydronephrosis, we're thinking urethra, we're thinking bladder, we're examining for any sort of obstructive mass in those two areas. Now, if the bladder is being obstructed and it can't release the pressure of that urine, we know that's when the bladder will often becomes inflamed or infected or hypertrophic. And so seeing a thick-walled bladder would indicate chronic distal obstruction. Now, also to keep in mind, we learned in our adult population that any wall thickening in a bladder that hasn't had surgery is abnormal. So even if it is not significant, if it's thickened, we definitely want to take note of that. Children with distal urinary tract obstruction often present with recurrent urinary tract infections, which makes total sense because we have that static urine. It's going to affect the urinary tract infections. Ultimately, it can affect kidney infections and then have that long chain of events and repercussions from. Another congenital abnormality, which is not terribly uncommon, is going to be the duplicated collecting system. Lots of times these are going to be incidental findings. It's the third most common cause of hydronephrosis in our pediatric population. The lesions or the duplications are recognized by dilatation of usually one of the poles. Most often it's going to be the upper pole calyx that we see dilated. And then we're going to see two separate renal pelvises. Now, with these duplications, remember from our adult system, they can be just the renal pelvises are duplicated, or it can be a complete duplication where we have two renal pelvises in one kidney, we have two ureters, and we have those two ureters that they can either come together prior to their insertion into the bladder, or they can stay as separate entities and create two insertions at the bladder. So whenever we find this, we need to assess for its extent. If we have more hydronephrosis in that upper pole, oftentimes it's because we're going to have more reflux in the ureter to the upper pole, and it may result in that upper pole becoming dysplastic or hypoplastic. The upper pole gets that more is more affected by hydronephrosis because it is the one that typically, if it does have a complete duplication all the way to the UVJ, it's usually the upper pole that inserts into the UVJ or has its UVJ insert into the bladder at an ectopic location. Therefore, as the bladder distends and it should compress the distal end of that ureter, that's not necessarily happening, and you're going to have more reflux, which means more reflux, more hydro, you get more infection, and so the upper pole is typically the pole most affected by this. So here's a couple examples of our duplicated collecting system. Here we see the lower pole, which in this particular case actually is more affected by hydronephrosis. We can see its renal pelvis and we can see its dilated ureter. Here's the upper pole, its dilated ureter. So at this point, it's hard to say if those ureters come together before they insert into the bladder, but there most certainly is a duplicated collecting system in this area. Here we see what is most likely an ectopic insert into the UVJ of the bladder caused by a duplicated collecting system. Because it's an abnormal insert, we're seeing that a urethrosil in that area has formed. Here's just another example where we have a dilated upper pole, a slightly dilated lower pole, and we can see that they have two renal pelvises, and so in this particular case, we'd have to follow it down and see if those ureters came together or if they stayed duplicated all the way into their insertion point. Okay, posterior urethral valves, we've talked about this quite a bit. I know you looked at it in OB, and so this is a very concerning abnormality. With posterior urethral valves, oftentimes we kind of teach that this is non-compatible with life. Some cases might not be as severe as others. So it is possible that you're going to have a live infant that has a posterior urethral valve. Remember that they develop that keyhole type bladder. These will account for about 10% of hydronephrosis cases. Usually or always it's going to be obstruction in a male patient. It occurs into about 1 in 8,000 young boys, and it's caused by a mucosal flap in the mid-urethral area or proximal urethral area that causes the obstruction. Now, when the bladder is formed, the urethra should go down the penis and exit. In this particular case, that obstruction can be somewhere in this region, and therefore it will obstruct flow from that point, and that's where you get that keyhole appearance for that is indicative of the posterior urethral valves. Now, if no urine is being released in utero, that's going to cause oligohydramnios, which is going to result in pulmonary hypoplasia. If for some reason some urine is being released, then they may be able to have still oligohydramnios, but at least enough fluid that they can breathe and develop their lungs to a certain extent. Now, sometimes all that pressure from this keyhole bladder or this obstruction will back up into the ureters and back up into the kidneys. And occasionally, where you would think this would be a bad thing, the kidneys will have so much pressure that they'll develop a leak and start leaking out some of that urine. In that case, it's almost a blessing to these babies that they have that leak, because it will take the pressure off of their kidneys, and they may be lucky enough to be born without their kidneys completely disrupted. Now, the other thing is if this is found in utero, they could attempt intrauterine surgery, where they would come in, do a surgical procedure, and open up that flap so that the fetal urine flow would be restored. They'd have more normal amniotic fluid levels, and they could develop their lungs and have a better chance at life. Okay. So patients are usually identified in utero. They get hydronephrosis, they get oligohydramnios, pulmonary hypoplasia, and it's usually the pulmonary hypoplasia that is going to be the cause of death in these young males. With this case, because you have so much pressure, because the bladder can't empty, it backs up into the ureters, you'll get megaureters, then you're going to get hydronephrosis. That hydronephrosis is going to compress those kidneys so much, causing stasis, compressing the blood flow. The kidneys can become dysplastic, and really by the time of birth, the parenchyma or the cortex can be nearly destroyed, and they can become, because there's so much damage to that tissue, you can see that tissue become very echogenic, cysts start to form, and things like that. Ureters, like I mentioned, you might get megaureter. That's going to demonstrate ureters that are dilated and tortuous. The bladder wall hasn't been able to empty, so that urine has been static, probably infected. That wall will become thickened, and you're going to see that dilated posterior urethra, just the area of the urethra that would be proximal within the baby to the actual obstruction. Now, sometimes ascites may be present, and this would be the case if that pole started to leak urine out into the abdominal cavity. Then you would see ascites present as perirenal or fluid around the kidney, or subcapsular fluid. Those patients that develop that leak, like I mentioned, usually have less dysplastic changes in their kidneys. However, that leak is never going to enter the amniotic sac, so it's going to help take the pressure off the kidneys, but it's not going to help with the pulmonary hypoplasia. So here's some examples of a patient that actually had posterior urethral valves, and you see all this pressure over time. The ureter is dilated, the renal pelvises and calyces are dilated, and it has a very echogenic appearance with the kidney. You also see some pararenal fluid here, meaning that kidney has probably developed a leak. If you look at the bladder, you can see readily that the bladder wall is very thickened. Here is a collection of fluid, so perhaps it's either from the kidney leak, or maybe the bladder has also started leaking because of the pressures. So oh, excuse me, this is the left kidney. Here's the bladder. Here's the bladder wall is thickened. So we have perinephric urinoma, or collection of fluid here, and we actually have ascites here, possibly another urinoma from leakage of the bladder. Now, if we're just, here's another example of a patient with, I believe, posterior urethral valves. Here you see, again, that cortex being compressed. This one looks like it has released some urine, and so we have that perinephric fluid. We do see that we have echogenicity here in the renal pyramids. That would indicate that there's probably, because of the compression by that excess urine, or the stasis causing infection, that there's been some damage to those renal pyramids already, causing them to fibrose and calcify. So again, in utero, these are major implications to the kidney. Okay, now prune belly syndrome, or also known as Eagle-Barrett syndrome, this is very closely associated with posterior urethral valves, but not quite exactly the same thing. So prune belly syndrome often has, a patient with prune belly syndrome often has posterior urethral valves. However, they also have absent abdominal muscles. So it's not just the posterior urethral valves causing that bladder to become big and distend the abdomen and make their abdomen look soft and prune belly-like. It's actually that they do have all those things occurring, but the muscle tone in their bellies is very abnormal anyway, and so it causes that belly to relax. And then when they drain the bladder, because there's no muscle tone, and now because that's been so distended by an enlarged bladder, they get that very prune-like appearance. This occurs in 1 in every 50,000 births, so it's pretty uncommon. It's very rare in females because, like I said, you don't necessarily have to have posterior urethral valves, but most of the time they do. Many infants with the prune belly syndrome have small cystic dysplastic kidneys because they've had those posterior urethral valves. Some can have hydronephrotic kidneys. They may, again, is keyword here, may have posterior urethral valves. That's why it's so easily confused with posterior urethral valves itself. But there's, like I said, there's an additional abnormality here where we have that absent abdominal muscles. Because of this, these babies end up with flaccid, dilated bladders. It separates the bladders separate the condition from posterior urethral valves and the abdominal wall. So if you see a baby with posterior urethral valves and they have some good muscle tone in their bladder and in their abdominal muscles, then it's probably just posterior urethral valves. If you see the posterior urethral valves and then they have no muscle in their abdomen, then it's going to be Eagle-Barrett syndrome. Either way, obstructed kidneys will usually occur, and it's important that this is probably an indication where they would send these babies to nuclear medicine for radionuclide scanning. The radionuclide scanning would help determine if there was any metabolism, if it was like obstructed or if it was non-functioning. So that would be also helpful in the final diagnosis of this. In addition to this, if the patient were to have just multicystic dysplastic kidneys, they would exhibit no function on the radionuclide scanning, and that would be a significant finding. So it's really going to be, when you have this group of issues, you're not really sure exactly what the cause of it is, that radionuclide scanning in nuclear medicine is going to be very helpful in the physician making that final diagnosis. Okay, now there's a number of different ways we can have cystic dysplastic kidneys. So it just tells us the cystic, we have cysts there. Dysplastic, they're bad forming kidneys. So they can be classified based off of several pathologic and radiographic or even sonographic findings. So sonographically, it may be difficult to differentiate between these diseases without family history. Some of them are going to be genetically passed down through generations, and so having that family history can be very, very helpful. We're going to see signs, but a lot of the signs of these different dysplastic kidneys are going to overlap, and so it's going to be hard to determine which one. Dysplastic kidneys can be small or large. They can have cysts they can have with or without cysts, and those cysts can be very small or very large. The cysts can involve just one portion of one kidney all the way to completely overtake both kidneys. So if we look at a subcategory of that cystic dysplastic kidney, most of our I'm going to backtrack here for a second. If we look at the overall multicystic dysplastic kidney, most common cystic dysplasia is going to develop from complete urethral obstruction in utero, where there probably was nothing wrong with the kidney, but because of urethral obstruction, it backed up, it increased the pressure in those kidneys, and when those cells started to die and break down and dilate and things like that, then it converted that normal tissue into cysts. We usually see that in the terminal tubules of the loop of Henle, and those cysts will develop in that region because of that high pressure system. You can get multiple cysts varying in size, as I mentioned before. If those cysts get very large, patients will present with large progressive cysts in their kidneys. Sometimes those can break down and decrease in size over time. Other times, the cyst will completely take over the kidney until the kidney is no longer identifiable. So there can be a lot of different variations of how these multicystic dysplastic kidneys develop, as well as how they resolve or continue. So here's a patient with multicystic dysplastic kidney. Here you can see larger cysts in one particular pole. Here you see that there's kidney cysts throughout this whole left kidney, and possibly some cysts extending into the spleen. Now this one's a little bit more difficult to see, but we see that there's a little bit of perinephric fluid here, and there's multiple cysts within the kidney. Here we can see a larger cyst in just one pole of the kidney. Over time, they followed this patient and they found that the tissue around that particular cyst actually degenerated, atrophied, and kind of died at that region of the kidney. So you're going to see some of those changes over time. Now, this chart I hesitated to include because it's a little bit confusing, but if you read down here, reliability of findings, where 1 is least reliable finding, where 4 is the most reliable finding. So if we look for this, a reniform cyst is a pretty reliable finding for hydronephrotic featured kidney. A lobular cyst is a pretty reliable finding for multicystic kidney. Parenchymal present, that probably indicates that it's not very reliable for a multicystic kidney. We don't know what it means. We can just see it. But if we see there's parenchyma, then hydronephrotic kidney is it's a pretty reliable indicator that it's a hydronephrotic kidney. You can kind of make your way down this chart and see which of these findings are really going to lead you towards one direction or the other. Okay, hypoplasia and dysplasia. So hypoplasia would be a small kidney. Dysplasia would be an abnormally formed kidney. So hypoplasia is usually a result of atrophy due to long-term infection or vascular occlusion of a particular kidney. So the kidney started to develop, was doing just fine, and because of long-term infection, compromising that kidney or vascular obstruction, reducing its blood supply, it's going to become hypoplastic, and then over time it can even become aplastic, where it basically fibroses and degenerates. Dysplastic kidneys, these could be large, they could be small, they could be anatomically abnormal, so they can have a number of different appearances, but basically it means it's an abnormally developed kidney. So we can see it with or without corticomedullary junction and pyramid, so we might not see that medulla well defined from the cortex. We can see it with or without visible cysts. We can see it with small or dilated renal pelvises, dilated ureters, caliectasis, urinary ascites, dilated calyces, and hyperechoic cortex. So one of the key things here, you see it's not with or without, it says hyperechoic cortex. So a dysplastic kidney most of the time will have that hyperechoic cortex, which indicates that those tissues aren't doing well, and they're probably not functional either. And that brings us to our polycystic kidney diseases. So in OB, you probably learned that infantile polycystic kidney disease is incompatible with life. And for the most part, that is true, but there can be some different subtypes to infantile polycystic kidney disease where they may have a little bit better outcome. In general, with infantile polycystic kidney disease, we also recognize that as autosomal recessive polycystic kidney disease, meaning both parents have to be carriers in order for you to have this disease. And with this, it's typically found in utero. And with the worst type of this infantile polycystic kidney disease, they're going to have microcysts throughout the entire kidneys. And those microcysts are going to be very, very small. And because they're so small, they're almost going to act like a contrast. So we're going to see these kidneys as large and echogenic. We're also going to know that these kidneys are not functioning. So you'll typically have a fetus that has large echogenic kidneys. You might see blood flow to them, but you're not going to see a normal sized bladder, especially after the 18-19 week mark. Over time, as the fetus progresses through pregnancy, you're going to see that they're not producing urine, therefore they're going to end up with oligohydramnios. And we know anytime they have oligohydramnios, they are not going to get development of the lungs. So really, they have two major things against them at birth. They're going to have pulmonary hypoplasia. So they're probably not going to survive because of that. Even if they did survive, they would have not functioning kidneys. Now, there are some specific types that are a little bit less invasive. So they could produce some urine and therefore not result in immediate death. So it wouldn't be completely, although it might be unlikely, it won't be completely unusual if you did come across a patient that did survive and does have infantile polycystic kidney disease. They would just have a non-lethal type. The other thing that's noted along with infantile or autosomal recessive polycystic kidney disease is that it's also associated with hepatic fibrosis. So here's where another kicker comes in. If they actually survived, they didn't have pulmonary hypoplasia, they ended up producing enough urine that they could, survive for some time, the odds of developing hepatic fibrosis, which will result in basically liver failure and portal hypertension and all of the things associated with that, the odds of that are very, very high. So even for these poor little patients that do survive, past birth, they're likely to die of liver disease eventually. Now, adult polycystic kidney disease or autosomal dominant, which is much less severe than the infantile, this is associated with hepatic fibrosis as well. So that also has to be another consideration in their care. And when we see those patients with many, many kidney cysts, and a family history of adult polycystic kidney disease, we have to really look at the liver as well and see if we're seeing fibrotic, cirrhotic changes there. Children who are lucky and have less extensive renal involvement may still present with the liver disease with that portal hypertension, as I mentioned. It's also associated with liver cysts, and the liver cysts in infantile are not as small as the kidney cysts are, and so they can be visualized on sonography without a microscope. Well, obviously, you don't have a microscope in sonography, but we could actually visualize them in sonography. So a good family history, probably genetic testing is going to be a big part of the picture when it comes to these polycystic kidney disease. Here's an example of an infantile polycystic disease where you see this very, very enlarged bulbous type kidney. In this particular case, you are starting to see, I don't know if these are cysts or if they're areas of necrosis. You can identify some cystic looking structures, but the rest of this kidney is filled probably with microcysts, which you're just seeing as an echogenicity. So this is a 1-day-old fetus that had a 36-week gestation and oligohydramnios, as we would expect, a massively distended abdomen, assuming their lungs probably are not in great shape either. So this little infant has a lot ahead of them. Here's another example. This one actually demonstrates some more cystic appearing areas, but we don't really know if those are necessarily cysts because we expect more microcysts. Those could be areas of necrosis. Okay, then we have our adult polycystic kidney disease. So with this, it can occur in the neonatal period or it can occur later in life. This is the autosomal dominant, and this is associated with a better life expectancy for sure than the infantile. So cysts are often in one or both kidneys, and cysts are often near or in the liver, pancreas, and the lungs as well. Cysts in neonates are usually going to start out as pretty small, where we may or may not be able to visualize them sonographically, but we would possibly see the change in size of those kidneys. The most common sonographic finding in the neonate is renal enlargement. 50% upon review of research, 50% have recognizable cysts, while 50% of them don't. When visible, the cysts typically appear to be in the cortical area more so than in the medulla and other regions. Probably the best way to separate adult from infantile polycystic disease is by getting that family history or screening the rest of the family, or there are genetic tests that might assist in that. It's a 75% chance, especially with the dominant disease, that other members in the family have the same disease. And here it breaks it down where infantile and adult both have bilateral involvement. They have large renal sizes. Cysts, though you can see, are pretty rare, and then it walks you through the recessive versus dominant. Now, these can be confused with glomerular kidney disease, which we're going to look at next. Glomerular cystic kidney disease is a rare condition. The kidneys become large and hyperechoic in the neonate, so it's going to look similar to the infantile polycystic kidney disease. But as these fetuses, they will produce some urine, and so they're going to most likely live more successfully than other fetuses or babies with the severe infantile polycystic kidney disease. But with age, the kidneys will become smaller and less echogenic. The cortical cysts will usually be microscopic, so we're going to see that enlargement and echogenicity of the kidneys, but not so much identify the cysts. The problem, you will have persistent loss of corticomedullary junction, so the cortex is going to kind of just appear as one unit with the medulla or the pyramids. Over time, these patients are also at risk of developing severe hepatic fibrosis, leading to portal tension, severe liver disease, and the effects of that. So in that respect, they're all the same. Now, medullary cystic disease, this is in the medulla or in that area of the columns of Bertine and the pyramids. This is a metabolic dysfunction in young adults. It can be classified as either medullary sponge disease or renal collecting tubular ectasia. So medullary sponge disease is when the pyramids start to develop microcysts, and those microcysts give it that echogenic appearance. So you would see the pyramids become very echogenic. It's going to look almost the same as renal collecting tubular ectasia. And if you remember what ectasia means, it just means dilation. And so renal collecting tubular ectasia would be dilation of the collecting tubes, which we know drain into the pyramids and can also cause that echogenic appearance. So both of these are going to demonstrate echogenic pyramids, and over time they're going to get more and more echogenic because in those cystic dilatations and in that tubular ectasia, they're actually going to develop calcium deposits, which will make this have that more spongy echogenic appearance for both of these issues. So aside from cysts, we are always having to be concerned about tumors in the kidney. So if a tumor is identified, obviously we need to find the origin of the mass if possible. So if it's originating from the kidney, that's important. If it's near the kidney, it could be from the spleen, from the liver, from the adrenal gland. So we always need to trace that, that tumor back to where it actually is originating from. We also have to ask ourselves, can we separate it from the liver or kidney or other organs, or is it involving multiple organs? We can ask ourselves if the mass is intra or retroperitoneal, and that's going to help us determine which organ it's associated with. We need to find the extent of the mass and see if it extends beyond the organ of origin, and look for any enlarged lymph nodes nearby, because that would indicate that it is spreading. We also have to see if any other adjacent Structures such as vessels have been displaced or invaded, or remember, a malignant tumor often causes thrombosis, and so we're going to look in those vessels and see if there's any thrombosis that could also be affecting the patient. And then metastasis. The liver is one of the most common organs to have metastasis to it. So that's going to be one of the primary places that we're going to be looking. That means extending the exam if necessary. Also, the nearby lymph nodes, that would be a metastasis. And then any other areas that could have direct extension. We also want to see if there's involvement of the contralateral kidney, because sometimes we will find these to be bilateral. So in our pediatric population, a Wilms tumor is the most common, and these are malignant renal tumors that peak at about age 3 to 4 years of life. They present as usually a palpable mass, meaning that they are kind of large oftentimes by the time that they are identified. They can cause pain, fever, malaise, weight loss, hematuria, obviously, because it could be disrupting the vascular system within that kidney, and then hypertension, as it might be affecting that glomerular, the juxtaglomerular junction, which is taking those blood pressure readings. If it's affecting that, it could be causing the renin-angiotensin feedback system to malfunction and result in hypertension. Again, looking at those nodes is essential. Remember, sometimes you won't even recognize the nodes, but because that IVC is so compressible, look for mass effect on that IVC. If it's a renal Wilms tumor, they often are able to invade the renal vein and IVC. They also can produce those thrombuses in those areas as well. If we have a really significant invasion of the renal vein to IVC, it can even directly extend to the heart from there. These can be bilateral tumors. Usually they're very large, pretty well circumscribed, smooth and homogeneous with an echotexture that's greater than the liver. Sometimes because they're compressing the normal tissue around them, it will create what we call that pseudocapsule, where there's not really a capsule, but the compression of that tissue makes it appear that there is. They can also, if they outgrow their blood supply, as we know, that can cause hypochondrocystic regions of necrosis. They can also cause compression of the renal sinus drainage, and that could cause those to dilate and look hypochondrocystic. They can fill the whole pelvic-calyceal system and obstruct the kidney, so this kidney can no longer drain, and then you're going to have hydronephrosis in that particular case. So here's a few examples of some very prominent Wilms tumors, so you can see why this would be a palpable mass. They can arise from the organ itself, or they can rise from a stalk attached to the organ, so that needs to be an important differentiation if you can find it. As I mentioned, they can have those areas of anicochondrocystic spaces. If they're rhabdoid tumors, they're more likely to have calcification outlining lobulations, and they can have a subcapsular hematoma. So these, you're going to obviously, in a case like this, you would recognize this as a mass. You can see in this particular image right here that it is definitely originating from the superior pole of that left kidney, very, very enlarged. Here on the CT, it's taking up the majority of the abdomen, outsizing the liver. So hopefully we're finding these before it gets to that point, but they're very aggressive. Another type of malignancy in the pediatric kidney that we might identify would be a nephroblastomatosis. And I just want to draw your attention to the terminology. So nephro is kidney, blasto are those cells that build or develop, and then atosis, remember that just basically means it's spread throughout. So this can often be a precursor to the Wilms tumor. These can have a couple different subtypes. The first, if it's diffuse, they will call it a pancortical type, where it basically replaces all the normal renal tissue. So pan means, throughout. So it would just be that cortical tissue just being replaced by tumor. Then there's a superficial type, and this type is subcapsular, and it's interesting how this works. And this is probably an example that we see here, where you see a relatively normal looking kidney, and then because of the cell lining within that capsule or rind around the kidney, that's actually where the tumor is going to start to grow. And you see that it's grown out from that capsule while leaving the inner components of the kidney somewhat unchanged. You can also have a multifocal form, and this is because of a persistence of primitive tissue along the columns of Bernstein. So remember, those columns of Bernstein, they're going to divide the renal pyramids. And so because of the primitive or, embryologic cell type in that region, they kind of act similar to, as I was mentioning, that rind around the kidney, and you can have the development of multiple areas of nephroblastoma in those regions. The tissue ranges in size and changes from very microscopic changes to very large masses that will affect the columns of Bernstein, so the medulla area, as well as the cortex. Those masses themselves can be hypoechoic, anechoic, isoechoic, or and only detectable if they alter the contour or distort the collecting system or the pyramids. So these might be a little bit harder to identify. Again, most of these you're not going to readily recognize and say, hey, that's a nephroblastoma. Lots of times it's going to be, you recognize the mass, document everything you can about that mass, and then it's going to be a biopsy that ultimately makes the final diagnosis. Another type of tumor is the multilocular cystic nephroma. So nephroma would be tumor, or kidney tumor. Multilocular would tell us that this is loculated and that it has cystic components. So this is actually a benign mass, and it has multiple thin-walled cysts, or it can be thin walls separating within one cyst. They're going to leave the regular renal parenchyma pretty normal, and we'll see that demarcated from the mass, and this can occur at any age. But again, because it's more cystic in nature, that kind of explains why it's going to be benign. It's not going to just take over the normal renal tissue. We have another type that's called the mesoblastic nephroma. So this is probably coming from those mesoderm germ cells. Blastic means growing, so we're getting a renal tumor from those mesoblastic cells. This is the most common congenital abdominal neoplasm seen in a neonate. So in those newborn babies, you're seeing a kidney tumor, this is kind of what you're suspecting. They can be unilateral or bilateral. They are benign. They're composed mostly of connective tissue, and they can unfortunately replace most of the renal parenchyma. So while they are benign, they can have really poor kidney function because the good functioning parenchyma is being replaced here. Sonographically, we're going to see these appear very similar to that Wilms tumor where they get large, they're homogeneous, they're smooth, with slightly increased echogenicity. So again, it may require a biopsy to determine which of the two of this is. These can have areas of necrosis and hemorrhage centrally, usually because they've outgrown their blood supply. So here's an example of a mesoblastic nephroma. As you see, I would have a significantly hard time differentiating this from the Wilms tumor, but you maybe in this particular instance, you do see a little bit more of that necrotic area. Okay, then we have the renal cell carcinoma, which we know from adults. It's often abbreviated with RCC. These are pretty rare in children. They're going to be of course, more common, one of our most common tumors in the adult kidney. These are highly malignant, and they are associated with tuberous sclerosis, which, remember, that's that combination of the mental retardation, abnormal chest shape, sometimes cysts other places, and then angiomyolipomas throughout the body, most notably in the kidney. Also associated with von Hippel-Lindau disease, and remember, that's the disease where really, amongst other things, they tend to have multiple cysts in many organ systems. So those two diseases are going to put somebody at higher risk of renal cell carcinoma. So these tumors are usually isoechoic or hypoechoic to the kidney. These, if the patient were to have a follow-up CT, they would see marked enhancement where there was a lot of contrast uptake by these renal cell carcinomas because they're going to have a high metabolism and they're going to need a lot of blood supply. How that translates to ultrasound, we're going to see hyperemia in these masses. Okay, now this goes back to then a benign mass, which is our angiomyolipoma. So remember, angio, that's going to be our blood vessel. Myo, that's going to be our muscle. Lipo, that's going to be our fat. And oma will be our tumor. So it's a tumor made of vascular tissue, muscle tissue, and fat. Now these, again, remember, they are highly associated with tuberous sclerosis. And patients with tuberous sclerosis may present with seizures, papillary rash, cardiac failure, and angiomyolipomas throughout the body and cysts in the kidney. Now, most of this is because of the tuberous sclerosis as a whole, not because of the angiomyolipoma. The angiomyolipoma is an indicator that there could be tuberous sclerosis. Tuberous sclerosis would then be the cause of all these other challenges. These are usually located within the renal cortex. They kind of remind me of the hemangioma in our adult liver. Pretty innate, echogenic, pretty decently outlined, homogeneous, hyperechoic, and they can, especially in the case of if you're seeing multiple angiomyolipomas or bilateral, then that does increase the probability that they are coming from the patient's tuberous sclerosis rather than just an unrelated finding. Here's just a couple examples of a couple patients. This one shows the multiple echogenic foci throughout the cortex and as well as simple cysts in the kidney. So we're seeing lots of foci, simple cysts of the kidney here. Here we see the spleen, and you can see that with this large mass of the kidney, it's going to be actually pretty difficult to determine and see whether it belongs to the spleen or the kidney. And so that's why those assessments, kind of following their blood flow back and that type of thing, are going to be really helpful. Splenic hematomas are also really common with tuberous sclerosis, so you might see those angiomyolipomas as well as hematoma. Now remember that hematoma, I always have to remind myself of that. Those are basically tumors of normal tissue that just start growing out of control. So it wouldn't be like a malignancy, a malignant cell that just started growing and becoming more and more aggressive. These are just your normal everyday splenic or renal or whatever tissue, and it just grows abnormally. Okay, so acquired pathologies of the kidney. So that means that something has happened. They weren't born with it. It's not congenital, but it's acquired. So the first type we're going to look at is pyelonephritis. So the pyelogram, or the pyle, as we use it in medical terminology, that would refer to the collecting duct system. So pyelonephritis would be inflammation-itis of the collecting duct and of the collecting, I'm saying collecting ducts, and what I'm intending is actually the collecting system. So like the calyces, the pelvis, and so on. So the pyelonephritis is going to be inflammation of that collecting system along with some of the tissue in the nephron or the kidney. So this usually occurs in children younger than 5 years old with urinary tract infections. And when we find this, they have to consider the possibility of a congenital abnormality. Now, if we look at this, children under 5, they're not going to be able to communicate that there's an issue as early as a child that's over 5 that is talking and aware and able to describe. And so that's probably one of the reasons this is more common in that younger population. The other thing is that if this happens, and oftentimes it's going to be caused by something else. And that's why they really assess these patients for congenital abnormalities, because it could be that there's an obstruction that's leading to stasis, and the stasis is leading to inflammation. It could be, that there's no peristalsis, and that leads to stasis, and so on and so forth. So they're not just looking at the pathology at this point, they're looking at what could be the cause of the pathology. The most common sonographic finding for this is enlargement of the kidneys. Now, it could be unilateral, it could be bilateral, and really the cause of it is going to determine whether it's unilateral or bilateral. If you have a patient that has posterior urethral valves backing up urine into the bladder, to the ureters, to the kidney, then that's going to cause stasis in both sides and probably result in inflammation in both sides. If you have it just affecting one side, then maybe it's an obstruction at the UVJ of one side, or reflux or something like that. So it's going to be an important part of the picture to determine whether it's bilateral, unilateral, what might be the cause. These can demonstrate areas of increased echogenicity of the cortical region, and even some areas of decreased echogenicity, depending on just some of the research that they've done. Additional indications for pyelonephritis would include loss of cortical medullary differentiation and thickening of the walls of the renal pelvis or ureter. Now, thickening of the walls is going to come from damage, edema, maybe even calcifications in those areas from long-term insults. The change in echogenicity in the cortex can really be the same. If it's early on, it might be the thickening or the hypoechoic appearance because of edema. If it's later, after the patient has had this chronically for a longer period of time, it could be because of fibrosis or atrophy of the cortex. So the variation in appearance really is just a piece of the overall clinical picture on this. So here's a couple examples that show really high levels of blood flow. Excuse me. Here's an example of the right kidney that has a well-circumscribed, very thick wall hypoechoic lesion, that this would indicate an area of collection of fluid from pyelonephritis. So it's kind of borderline probably turning into an abscess here. Okay. Here's an example of urothelial thickening. So when we say urothelial, that would be the epithelial lining of the ureter. So here we remember that epithelial lining of the ureter comes in, and it also covers the inside of the renal pelvis. So here you see the thickening of the walls of that renal pelvis, and that's from that inflammation from pyelonephritis. So that's going to be something that you really want to look for in cases with this. Now, it is pyelonephritis is going to cause elevated white blood count, fever. They might have gross or microscopic hematuria. In general feeling of unwell. These are going to be usually pretty sick, uncomfortable patients. Okay, now if pyelonephritis or some other issue is not resolved, we know that lots of times our body will go and try to circumscribe that and try and make sure that it doesn't spread throughout the rest of the body. So one of the ways that the body does this, as we know, is an abscess. And so if we have an infection or an issue that's large enough to create an abscess, we know we're going to have fever, elevated white blood count. We know that we're probably going to feel very, very fatigued, pain. We know that an abscess really is bringing a lot of blood supply to the area, so we're going to have hyperemia in the abscess walls. Those walls will usually appear hypoechoic and thick. They can have irregular, look kind of scruffy, and they'll usually an abscess will have distal acoustic enhancement. We know that abscess is basically containing a lot of material that's slough off of white blood cells attacking the infection, and so we'll have a lot of those dead cells floating around then in there looking like mobile debris. If we have necrosis of the area of some of those the bacteria and the infection, inflammation, or even of the white blood cells, those can produce gas, and so we're looking for the dirty shadow that may indicate that there's gas there. These are usually treated with antibiotic therapy, or they can have percutaneous surgical drainage, meaning that percutaneous would be through the skin, where they could insert a needle, drain the abscess, and then wash it, and then inject antibiotics right into the abscess itself. It could also be treated, with IV antibiotics. It's going to kind of depend on the situation. These can lead to mild scarring of the kidney, and scars can be small, and if they're around the calyces, we may not be able to see those. If they are compressing the calyces, and then we may actually be able to see that there's dilatation. If it's affected the cortex, it can be identified with an overall decrease in kidney size. And so that's when referring, especially in our pediatrics, to the kidney length charts. They're going to be important. Now, with acute pyelonephritis, the renal appearance will become enlarged. And so if it's going to be improving, we want to see it go back to its baseline. So they can monitor the kidney size and follow renal growth. Follow-up renal growth should be done every 2 weeks. And what we're looking for is that it's not staying enlarged, it's going back to its normal size, but then we want to make sure that it also doesn't regress and get smaller than its original normal size, because that could indicate that long-term damage was done. With children that have continuous lower urinary tract infections, often from reflux or other congenital malformations, renal measurements may be important to follow over time to ensure that we're not getting that regression of kidney size. Sonography can also be used to seek anatomic causes of infection, specifically obstruction, like those posterior urethral valves or reflux of the UVJs because of inaccurate insertion points, things like that. Okay, now nephrocalcinosis. So this is where there's a deposit in calcium of the kidney associated with increased urine calcium. So these patients might have elevated levels of calcium on urinalysis. Both kidneys are typically affected with this, and they're going to have focal echogenicities. Those echogenicities, because it's calcium, we would expect to see acoustic shadowing, but sometimes you don't. Kidneys with this are typically normally sized, but they have abnormality in their appearance at the corticomedullary junction. So where that cortex meets the top of the pyramids, we don't see that normal echogenicity change. Now in this, there's typically a very high increase of echogenicity of the renal pyramids. This is usually present with sloughed papilla. So remember, papilla is the area of the pyramids that drain the urine into the calyces. And so if there's a lot of damage, a lot of calcium buildup in that area, they can slough off that good tissue. That could lead to bleeding, that could lead to blood clots. They're also going to be immunocompromised sometimes, so fungus balls can collect here, cellular debris, and often find proteinuria. Children at risk of urolithiasis due to urinary stasis, children are at risk for this due to urinary stasis or infection. So anything that's going to cause that back up into the system can elevate the levels of calcium in the urine, can lead to that absorption of calcium replacing the pyramids, and then all of this additional issues after that occurs. So here's an example of nephrocalcitosis. So you can see very echogenic. It reminds me a little bit of medullary sponge kidney, but in this particular case, they would have a slightly different clinical presentation. Their labs would be a little bit different. They'd have that urine calcitosis. They're going to be a little bit more echogenic than even the medullary sponge kidney, and over time, it can really affect the function of those kidneys. All right, that brings us to renal vascular disease, which is, hopefully affecting our children or our pediatric population much less than our adults, because they haven't introduced all the toxins that we adults like to do into their system, but it still is possible. So often with our pediatric population, renal vascular disease is a result of trauma or basically congenital conditions, rather than with, we might have renal vascular disease in an adult that is a longtime smoker, maybe diabetic. Those kinds of things are more likely to cause renal vascular disease in our adult population. In children, it's usually something congenital or trauma. Now, anytime there's renal vascular disease, they're at higher risk. So even if it's an arterial disease, this patient is still at higher risk for renal vein thrombosis, which we know can cause the kidney to it's pumping arterial blood in and it can't get out. And so it becomes very congested. It increases the pressure. That pressure can press on the normal functioning nephrons, and it can ultimately cause a decrease in function, and ultimately, if it goes on chronically, it could cause death of that whole kidney. Clot formation and emboli can occur in the renal arteries, and then they can actually move that to the renal vein. One cause of neonatal clot formation, especially in our premature population, would be from umbilical artery catheterization. So with that, that's going to be one of their concerns of having to undergo that procedure. In small infants, it can be difficult to detect actual renal vein thrombosis because it occurs in the very small veins, not the large veins where we might actually see a thrombus. So you're really looking at diffuse enlargement of areas of the kidney in this particular case, because it's going to be out there in the smaller peripheral vessels in which, again, the kidney is getting blood flow out there, but it can't get it back through the venous system because of the thrombus. Trauma to kidneys for our pediatrics is pretty unusual. Most of the time with infants, hopefully it's related to birth injury. Obviously, it could be due to child abuse. But because of the superficial location of the kidneys in our little newborns, most of the time the renal trauma is from the trauma of delivery. So this can cause a flank mass in the newborn, and it's often more adrenal than renal, because the adrenal has a large blood supply, like the kidney, but even maybe more so, and it can cause parenchymal hemorrhage in that area. So anytime we're looking at trauma, we're going to be concerned about a hematoma. So that hemorrhage is going to create a hematoma. The hematoma is going to act like a clot. So we're going to see that transition from hypoechoic to anechoic to low-level echoes to moderate-level echoes to complex to ultimately resolving and becoming anechoic, and then being resorbed or becoming calcified as a chronic clot. The hemorrhages that we see can be subcapsular, meaning that they're underneath the capsule between the actual kidney and the capsule, or they can be perinephric, where the trauma is external to the kidney or the bleeding is coming outside of the kidney. For imaging renal trauma in a child, CT is often the modality of choice because they can see the extent at which that trauma goes in a very short length of time. Woohoo, we finished the kidney. So on to the bladder. So the urinary bladder in infants, it's considered an abdominal organ. It really doesn't settle into the pelvis until later in life. Now, because it's an abdominal organ, and because especially infants or even younger toddlers have not really developed the control of micturition at that point, it can be challenging to get images of a full urinary bladder in our really young population because the pressure on the bladder causes it to evacuate. So in order to get a full bladder, it's not uncommon to have to use a Foley catheter. Oftentimes, if you're in a radiology department, it's going to be a radiology nurse that inserts that. Might have to be an ER nurse if you're working in a general hospital, things like that. So don't be afraid if you need a full bladder and can't get one. Don't be afraid to reach out for help and request a Foley, or work through whatever the chain of command at your site is to make sure that you have access to a Foley so you can actually assess the urinary bladder. Now, in a very distended bladder in normal neonates is really rare unless the mother, while the baby was still inside, received drugs, or the infant received drugs to inhibit voiding. Otherwise, they're going to have really pretty small bladders because they're just urinating as, just willy-nilly. So, they don't really have that time for the bladder to get large. Now, if there is bladder distension, that could be an indication that there's some sort of major issue. It could be because of neurogenic disease, where you have a neurogenic bladder and it's not emptying. It could be because of a pelvic mass having mass effect and not allowing it to empty. It could be because they have posterior urethral valves, or maybe they have a large nephrolithiasis stuck in the urethra. So it could be a number of different things causing bladder distension. None of them would be normal. So the other thing is really important. I made this mistake one time. Cystic pelvic masses can be confused with a bladder. So you must take care that you're differentiating, that you're always finding if there could be a bladder. If there's two cystic masses, you never want to mistake a cystic mass for the bladder. And just a quick story, because I know you're here for so long. But when I was a student, I was doing a transvaginal ultrasound, and I kept sending this patient back to the bathroom because her bladder was full. Okay, you got to try again. You got to go back to the bathroom. Your bladder's full, and I'm trying to get this transvag. I didn't say it that way, but anyway, come to find out, I had my supervising tech come in and work with me a little bit, and after looking around, there was a mass that was attached, or excuse me, there was a cyst that was attached to an ovary right in the bladder position. So what I thought was her bladder not emptying was actually a cyst. This can happen. Okay, now this is pretty familiar because we didn't go over the bladder too long ago, so we're going to talk about urachal abnormalities. So in our pediatric population, the urachus can still be patent or persistent. So the urachus, as you know, is that tubular structure that is continuous off the anterior superior bladder, and it extends along the line of the umbilical cord all the way out through the umbilicus. Now, usually during the fourth or fifth month of gestation, this should start to narrow and fibrose and ultimately become basically a ligament. It should be completely obliterated and fibrotic at or before birth. So if you have a persistent urachus, that is when any one component of the urachal structure remains open. So it didn't close off completely, it didn't fibrose. So patients may present with abdominal mass after the umbilical cord is clamped at birth, and this can turn into infection because if there's urine in that urachus, then it will become very static, and then that could result in infection. Now we know sometimes you can have a urachal sinus, you can have a urachal cyst, you can have a urachal, I'm going to forget the other one off the top of my head. So it can stay open, patent, or persistent all the way from the bladder to the umbilical cord. It can seal off from the bladder near to at the bladder and then remain open from the umbilicus in. I think that's the sinus. It can close at the umbilicus but remain open off the top of the bladder, and it can close at both ends while trapping some urine inside, which would be the urachal cyst. So there's all different options for these. Just know that if somehow it is containing static urine or it has surrounded static urine, the risk of infection is going to go up. Urachal abnormalities are associated with posterior urethral valves. We already talked about this pretty extensively. So again, it's in those boys. It's usually a 1 in 8,000 risk factor for this. It can be devastating if they don't address it and if it's complete, because it will result in pulmonary hypoplasia if it's complete, and it will also provide such a high pressure system into the renals that it will compress the renal tissue and ultimately usually destroy them. So with the posterior urethral valves, it's not uncommon to see that urachus not close because that will provide some release of pressure. The bladder will also be thickened because it's going to have so much pressure on it. The ureters are going to be tortuous and enlarged. So all those things we've kind of already done. Here's an example of a urachus that here is open on the bladder end. Here's one from bladder to umbilicus that is patent all the way through. Okay, bladder tumors. Rhabdomyosarcoma, I showed you a picture of how aggressive this can get. It can arise from the bladder, prostate, uterus, or vagina of children. If it's there, it can grow right out of the body. These are very aggressive. They are almost going to have like a polypoid mass, so homogeneous polypoidal mass, almost like a grape seed appearance. Very aggressive. They get big, they grow fast. So with that, patients are going to present with hematuria because it's in the bladder. It will be growing, it will be bleeding, it will be putting blood in with the urine. Dysuria, obviously it can cause pain. Depending on its location, it could cause the inability to completely urinate or urinary retention. And it will also, if it's causing urinary retention, it can also cause then urinary tract infection. Any masses within the bladder, we're going to want to assess those. We're going to want to look to see if they're attached to the bladder wall. Maybe it could be a thrombus, so we have to roll that patient. We have to make sure, identify the stock or the blood supply to show that the mass is is attached. Now, the bladder can also be obstructed by a sacrococcygeal teratoma. So remember, those typically, we looked at them, I think last week, where they can grow really out. The backside, we typically think of them as appearing on the posterior aspect of the patient born with this. They can actually grow anterior to the sacrum into the body too, and those can then either compress the bladder or they can even grow into the bladder. Okay, here's a few examples of, this is a patient with Ewing sarcoma, so not one of them that we've talked about, but he has a large mass in the bladder. Obviously, that's probably obstructing the bladder flow, and you look at that bladder wall, how thick it is. It's very abnormal. This, though, has a pretty low blood flow. Over here, we can see that this is, this is just demonstrating the flow of urine into the bladder from an abnormally positioned. Oh, I'm sorry. Okay, the purpose of this is actually showing the blood flow into a particular mass. So this shadowing entity looks like it could be just a stone, but if we look at it more closely, it does have blood flow. So we know a stone wouldn't have blood flow, so this would actually be representative of a mass. Okay, urinary bladder infection is called cystitis. This is the most common urinary tract infection in kids. Obviously, it's more common in girls because of that shorter urethra and the probability of introducing fecal matter over the urethra. So it's much more common in girls. With cystitis, if it's treated immediately, you may not see anything sonographically. If it's there and it's been longer lasting, the bladder wall may become thickened. That's because it's going to be edematous as the body tries to address that inflammation. Anything measuring greater than 0.3 centimeters with a full bladder would be considered a bladder thickening. Okay. Bladder wall changes can be asymmetrical, but remember, bladder thickening is never normal. An asymmetric bladder is never normal unless there's been surgery. Now, with cystitis, lots of times it can compromise the ability to micturate or urinate, and so urine, and it could have been caused by obstruction or something in the first place. Either way, the urine would become static and bladder calculi are going to be more likely to form. That being said, they're usually they're a little bit less common that you get bladder calculi in children than the adult population. Children with active urinary tract bleeding can show clots or blood in the bladder. We don't know necessarily without further investigation if that clot or blood is coming from the bladder itself or if the bladder is holding what's come down from the kidneys. Bladder perforation and trauma are not best evaluated for sonography. You might get a really good quick look to see if there's urinoma and a very small bladder, but most of the time it's going to require cystography where they'd introduce a scope of the urethra into the bladder for that diagnosis. Doesn't mean we won't be asked to, like as kind of part of a FAST exam, to take a look and see if that bladder is Okay, on to adrenal glands. So adrenal glands, diagnostic sonography is useful for neonatal adrenal glands more so than in adults. Well, we almost never use them for adults. We do for our neonates, and that's because the adrenal glands are more prominent in our neonatal population. In addition, neonates have very little body fat and very little distance between, the scanning window and the adrenals themselves. So that makes our scanning of the adrenals in our neonate population much easier. The right adrenal gland should be able to be successfully imaged about 97% of the time, while the left is a little bit harder, so it's about 83% of the time in our neonate population. So pretty successful at usually being able to see and assess. So patient preparation for this, kind of like with the kidneys, there's really no required preparation. If they can fast, that's fantastic. It might reduce the bowel gas. We do encourage patients to be well hydrated. That's going to cause, kind of the kidneys to appear better, which can kind of help us see the adrenals better as well. Adrenal visualization could be limited, as you guys well know, because of attenuation by bowel gas. And that bowel gas causing the majority of our issues, it can be helpful to do like I said, to do the fasting, although again, it's not required. So for a 1-year-old, you don't want to fast much longer than 3 hours. For a 1 to 5-year-old, you don't want to go more than 6 hours. And for children 12 and older, you don't want to go, or excuse me, yeah, I would say 12. Maybe over 5, anywhere over 5, you could try for 12 hours. But it's going to be really hard in that 5 to probably 11 or 12 population. For adrenals, you're going to scan kind of like we did for our practice lab for adrenals. The coronal assessment is usually going to be very helpful. So, but in newborns, you can also scan from posteriorly with them in the prone position. Make sure that you're moving the patient decubitus, oblique, however you need to get around that bowel gas, and look through as many windows as you can until you find the best one. For the left adrenal gland, you want to use that cava suprarenal line position. So you're basically going to go to the coronal left side and scan through the kidney and with the IVC appearing in your far field. And in that view, you should be able to pick up the adrenal. Putting the patient in 45 degrees LPO, so left posterior oblique, for transverse scans can also help. And I'm going to leave that at that. Okay, now the normal sonographic appearance of our adrenal glands. So we can, because they are still, even in a neonate, a little bit challenging to see, especially if we're not looking for them, we really want to count on our surrounding landmarks to guide us towards them. So the right adrenal gland is pyramid shaped. So you'd say it was maybe a V or a Y shaped in transverse. It sits over the kidney between the right crux of the diaphragm and the liver, posterior to the IVC. So with this, you're going to be scanning usually from the coronal aspect up the superior kidney till you hit the liver, and then make sure you're not confusing the adrenal gland with the crux of the diaphragm, as they have somewhat similar appearances, but in the neonate, they should be much larger than the crux. Any mass in the right adrenal area must be differentiated from renal, hepatic, and retrocaval lymph node masses. So if you see something in that right upper quadrant, you can't necessarily just assume it's adrenal, and also don't just neglect that it could be the adrenal. You have to make sure and draw the mass back to where it is attached. The left adrenal is a little bit harder to see because of the difference in anatomy on the left side and the lack of that liver window. It's a little bit more crescent shaped and lies anterior to the upper pole of the left kidney and lateral, in this case, to the left crux of the diaphragm. And posterior to that pancreatic tail. And you guys know how well you see the pancreatic tail sometimes, so you can see why this would be more challenging on the left. Structures are usually distinguishable by differing sonographic texture, so really look for those texture changes. And we have some examples coming up here. Okay, so here is an example where you can see that texture change where it has that hypoechoic region surrounding a little bit more echogenic region, and it really has that V, kind of a gyri type of shape as well. Okay, so sonographic studies should note the size of the adrenal glands. Normal adrenal length ranges from about 0.9 to 3.6 centimeters, so it's kind of a massive range. The width is usually about 0.2 to 0.5 centimeters. They have found that there's no statistic significance between differences in right and left adrenals. So, we can say for a kidney, if one's 2 centimeters longer than the other, then that would indicate an issue. They haven't found those same types of patterns in the adrenals. It's important to recognize too, we talked about renal agenesis earlier, that if the kidney in one renal fossa never forms, then that adrenal gland has a lot more room and it can kind of spread out and kind of take up more of that fossa. So make sure you're not confusing an adrenal gland calling it a kidney when there's a kidney that doesn't exist. Okay, adrenal gland tumors. So we know that the adrenal gland is very involved with our hormones. So adrenal gland tumors can have significant impact on hormones as well as blood pressure, as well as our flight or fight response. So the tumors in adrenal glands appear as discrete lesions, usually in the superior area and medial area of the upper pole of the kidneys. So these, we would again have to find this tumor and really assess, is it part of the kidney or is it part of the adrenal gland? If it's part of the adrenal gland, it can still compress and deform the kidney, which makes this separation of the two that much more difficult. Okay, now really quick, and I think I accidentally skipped over a slide a little bit earlier and it won't let me go back. So really quick review about the adrenal glands. Remember that we have the cortex and we have the medulla. Okay, newborns will have a a larger cortex because they're still exiting the fetal stage. So they're transitioning, and that cortex will get smaller over time. And that's one of the reasons that we can see these adrenals better in our newborns. But the cortex itself is going to be made up of the GFR, right? So the glomerulosa layer, the fasciculata layer, and the reticularis layer. Now, I'm not saying glomerular, the G layer, that one is going to be the one that is associated with aldosterone. So it's going to have, it is going to have some impact on blood pressures, right? The F is the fasciculata. That one is going to be the one that's associated with your glucocorticoids. And then your R is going to be the reticularis, and that is going to be the one associated with your sex hormones. And then inside that we have the medulla, which contains pheochrome cells, or also known as chromaffin cells. And it's that medulla that's responsible for your fight or flight response, the release of epinephrine and norepinephrine. So just that quick review, if we see a tumor that's a neuroblastoma, remember that the medulla is a combination of neural and adrenal tissue. So a neuroblastoma is usually going to come from the medulla of the adrenal. So this is the most common of the adrenal tumors. Half the cases appear in the first year of life. Almost all involve the adrenal gland. Children present with a palpable mass here. It can cause urinary and GI symptoms, and then it can cause fever, weight loss, abdominal distension, irritability, hypertension, and or anemia. Now, if we look at this, why does it cause hypertension? Well, it's affecting the medulla. The medulla causes release of epinephrine and norepinephrine. That causes our heart to beat faster, our vessels to constrict, and additional things in our pulse to increase. So a lot of this is going to be due to the origin of this tumor. Prognosis is better in neonates and infants, and dependent on the tumor origin and the extent of the disease, if they can get that tumor out without having this child have severe hypertension for a long period of time, and they're able to get that out before it does damage to the heart, it's going to be a lot better clinically for the patient. In addition, it gives it less time for the tumor to spread. Calcification of these tumors can be seen. Okay, additionally, with the neuroblastoma, what we might see is it could be predominantly echogenic with those calcifications with poorly defined borders. If it does have calcifications, they will usually shadow in this area, and if it outgrows its blood supply, then we're going to see those areas of a complexity because of necrosis. In a classic case of neuroblastoma, we can usually see the relationship of the tumor to the kidney as separate. It typically also displaces the kidney downward and outward. So you might see that you're finding it lower and lateral to where you expect, and then you find a large mass where you would expect the kidney to be. Because of the challenges with the adrenals, and to look for the extent of how far these may go if they're affecting the lymphatic system or anything else, CT may actually be a better option, or MRI. So here's a couple examples where here we see, I think this one is probably most prominent. Here's the kidney. We see this large mass separate from the renal cortex. So we can make out the renal cortex all the way around here. This is separate to it. Then, of course, once they do the biopsy, they'll have be able to determine which type of adrenal mass it is. But the clinical symptoms of hypertension and other things, those flight or fight sort of responses are going to probably point them in the right direction before they even get the biopsy done. Here you can see just how large these can get. Here's one with a little area of necrosis in the center because it's outgrown its blood supply. Okay, then we have adrenocortical carcinoma. So this is telling us it's in the cortex, so we're not going to have those high levels of hormones causing fight or flight response, but these can affect that reticularis region, and they can cause virilization. So virilization symptoms would be a female patient demonstrating more male-like patterns. So it is linked, interestingly enough, to fetal alcohol syndrome or congenital hypertrophy and Beckwith-Weidman syndrome, which is the one with the enlarged macroglossa, the enlarged tongue. Other clinical signs of this would include abdominal mass because it can take up space, a deepened voice, which would often because of the virilization, meaning there's extra testosterone being released, that's going to deepen the voice. It can cause hypertension, seizures, and sometimes weight loss. These are highly malignant and locally invasive, and so they can basically work their way through all the layers in some of the adrenal, and then some of their symptoms could be related to not just one layer, not just the reticularis layer, but the other layers as well. These are highly malignant. They're more common in adults than children, and they are rapidly and aggressively growing, so they can metastasize quickly to liver, lung, bone, and brain, as well as lymphatics. Okay, so another type would be the pheochromocytoma. So this tells us specifically it's the pheochrome cells. Those are very responsible for that fight or flight response, or the epinephrine, norepinephrine. So with these are highly functioning, meaning if the pheochrome cells normally release epinephrine, norepinephrine when needed, these are functioning all the time, releasing those hormones into our body. So these are going to include, the symptoms of this will include all of those fight or flight responses. So hypertension, headaches, palpitations, diaphoresis, anxiety, all those things that you would associate with feeling the fight or flight response, except it wouldn't end. So these can have a wide range of appearances, so it's going to be very dependent on the clinical symptoms and then probably biopsy results to diagnose this. Here's a couple of examples. This is just showing massive abdominal distension. When they looked more carefully at this, they see that there's this huge adrenal mass off the right kidney, completely grown around and encompassing the aorta. So these can become very aggressive. Okay, metastasis from the adrenal glands. This is usually a non-specific and can look like any other tumor, so it would have to be identified and then biopsy to determine where it came from. They can be bilateral and large. They can be solid, but they have varying degrees of echogenicity, so it's going to make it really challenging to see a metastasis in the liver and know it came from the adrenal gland. Okay, hemorrhage of the adrenal gland. This usually results from a premature birth, neonatal sepsis, or hypoxia or trauma at birth. And in this particular case, the adrenal glands are susceptible to hemorrhage because they're large size and high vascularity. Also, them being very superficial in the newborn fetus or the to-be-born fetus would cause them to more easily be traumatized. If there is a hemorrhage, sometimes if it's a large hemorrhage, you're going to see that palpable mass. The baby could demonstrate anemia or a dropping hematocrit. They can have hypotension, even go into hypotensive shock. They may demonstrate hyponatremia or low sodium levels, jaundice, and in males, they can even see scrotal discoloration because the blood that is exiting from the adrenal may actually go and collect in the scrotal sac. A small unilateral, these are usually small and unilateral, and the right gland is associated with an ipsilateral or the same side intrathoracic injury. Appearance of a hemorrhage is always going to depend on the age of the hemorrhage, as it's going to follow that hematoma process. With these, they usually are going to repeat sonography every 3 to 5 day intervals to observe the changes and watch it as it changed from hopefully from anechoic to more solid, and then basically break back down into the cystic and be resorbed. Okay, with hemorrhage, in most cases, it will break back down, shrink rapidly, and it might have long-term calcifications from leftover chronic thrombus, but it should usually get back to normal. So here you see the kidney, here you see a major adrenal hematoma next to it. Now, initially, the calcifications can outline the anechoic adrenal gland like a rim. Hopefully, those will break down and the calcifications will become more compact and then look more triangular as that adrenal retakes its kind of V or Y shape. Here's an example of, a larger hematoma, and it's kind of in its complex stage here, and they're going to be monitoring this for regression. Okay, cysts in the adrenal glands are pretty rare. Usually they're unilateral and usually asymptomatic, but they can become large, and then if they become large enough and they affect that glomerulosis layer, then they can affect the angiotensin-renin feedback system, and that would result in hypertension. Cysts are going to appear like cysts, so these would follow all the same criteria for a cyst. They can also displace the kidney inferiorly, and so that would be a concern. And actually, that might draw your attention by noting the abnormal placement of the kidney. It might draw your attention to the renal gland or adrenal gland. Excuse me. Abscesses can occur in the adrenal gland just like anywhere else. So anytime there is infection or inflammation here, it is at risk of an abscess. Most of the time, with normal immunity, you're going to resolve it before it becomes an abscess, but it is possible. These can be caused by bacterial seeding from adrenal hemorrhage, where there was bacteria, it settled, it got static, it was able to set up its culture and grow. So it's going to act just like an abscess. You're going to have fevers, chills, abdominal pain. You're going to have an elevated white blood count. Oftentimes these are unilateral, like I said, because they're caused sometimes by seeding from the hemorrhage. They're going to be relatively anechoic, posterior enhancement, superior to the kidney, can contain echogenic debris, can contain gas, can contain fluid debris levels. So all those things that are classic to an abscess. Failure of an adrenal hemorrhage to resolve is going to increase the size of the adrenal in an infant, and it could cause fever. At that point, it should raise suspicion of an abscess. So they may really be watching those newborns with adrenal trauma and hemorrhage closely to ensure it does not become an abscess. Okay, in cases of renal agenesis, I already kind of mentioned that the adrenal glands can become a little bit elongated, thicker, and they can take on more of that renal fossa, and so you'll see a little bit of a change in their shape. Okay, congenital adrenal hyperplasia. So this is an autosomal recessive metabolic deficiency where the enzymes that are required for normal steroid biosynthesis or production of those normal steroids is not occurring. And so this is going to affect, again, that reticularis layer, resulting in virilization of females and excessive masculinization in males. They can cause advanced somatic development in both sexes, meaning somatic development would be those secondary sex organs. So it would be like in a female, if they're having virilization, they might get that increased facial hair. They might get hair on their chest. They might get other male-like qualities in those somatic cells. Adrenocortical adenomas can develop from hyperplastic tissue when the adrenals are hyperstimulated, usually from some sort of exogenous introduction of hormones. So you're presenting these exogenous hormones, the adrenal cortex gets hyperstimulated, an adenoma develops, and then it takes on and produces too many hormones, leading to this excess level of testosterone. Okay, with this, the adrenal glands will become markedly enlarged, but they'll still maintain their characteristic anechoic cortex and echogenic medulla appearance. Adrenal measurements greater than 20 millimeters or 2 centimeters would be suspicious for congenital adrenal hyperplasia. Now, finally, we're pretty much done. So, because no singular imaging approach can do perfect at everything, we really want to be able in the pediatric population to understand which imaging approaches are going to benefit the patient and going to be most appropriate in particular circumstances. So we're going to do a really quick evaluation of some of the strengths and weaknesses of our imaging modalities. We know for ultrasound that our strength is no radiation, we're cheap, we're fast, we're accessible. We know our con is that sometimes we can't see things well. We're very limited in our fields of view. When we look at radiographic procedures, some of the most common ones for our pediatric patients would be that VCUG, voiding cystourethrogram, that I had talked about yesterday, or excuse me, previously in our recording, and an intravenous pyelogram where they would inject contrast and then take x-rays as the kidneys uptook that contrast over time, and then watch the contrast fill their ureters, bladder, etc. So both of these are really great exams. They're not that expensive, but they may require very young patients to be sedated, so that would increase their risk. It also would require radiation, and so those would be cons. In fact, so much so that the IVP especially is very limited use in pediatrics and actually in the general population anymore. The other thing with both, with especially the IVP, we have to inject contrast, which can have some pretty significant contrast reactions, and so that would be a secondary issue with that particular exam. That brings us to CT, which provides us excellent global images. So where we may be having to focus on one little thing at a time in sonography and working through windows, working so hard, CT can zip through anatomy. It's fast. It's available most places. It's and it can give a good global view. For some of the disadvantages of CT is that it's expensive. The radiation doses are really high. It too uses contrast media, which could cause a reaction, or the contrast media can be very hard on the kidneys. But CT is wonderful when it comes to finding a kidney stone, looking at extensive tumors and masses. It doesn't give you a ton of detail, but just seeing where it's located can be a really good starting point. And especially not knowing how far something extends or where a metastasis is spread to, that overall global view that this gives is really beneficial. That brings us to MRI. So MRI will often in our pediatrics require sedation, so there is a risk with that. MRI is less available and it's more expensive. It is excellent at demonstrating soft tissue contrast, so it's good for diagnosing renal masses, adrenal hemorrhage, adrenal and cortical carcinomas, metastasis, pheochromocytomas, neuroblastomas. It can really just provide such great soft tissue detail that it can tell us almost anything we want to know. It doesn't have as much real-time functional information often as our sonography does, but the quality of the images it provides is a great global view, kind of like CT, much less patient dependent than we are in sonography. The other benefit of MRI is that it has no radiation. It's completely magnetic. They do provide contrast sometimes, which is a risk, and then the expense is pretty high. Okay, that brings us to nuclear medicine, which isn't exceptionally expensive, but it's usually less accessible. It does provide excellent functional information, although the image is not always pretty. They tell us excellent functional information about the urinary tract, which can be useful in our young population. Usually when they're assessing the urinary tract, they're going to have to use MIBG for detecting adrenal tumors, fibrosis, distorted anatomy, or other things. The disadvantages of nuclear medicine is that they are actually injecting a radionuclide or radioactivity into the body, and so that's obviously a concern, especially on our pediatric population. And then we have positron emission tomography. This is like a similarity where we can actually look for metabolic changes within imaging that kind of looks up something like a CT. So it is a kind of a combination of nuclear medicine and CT. So we get the soft tissue information from CT, but the nuclear medicine information about metabolism. So this is excellent in looking to see if metastasis is spread and things like that. These are expensive, they're less available, they're going to require the injection of those radionuclides oftentimes, and so they have a high cost and can be challenging that way. And with that, we have finished our pediatrics. The day has come that we never thought would get here. So I'm going to let you read through our summary. We will wrap this up and move on next week. Have a wonderful day.